we'll get started now. Thanks for joining us tonight. This is Maloney, and I'm with Cutting Edge Lasers, and I will be your host tonight. We are very pleased and honored to have Dr. Tracy Basso, owner of Davis Foot and Ankle Center, with us. Dr. Basso is one of our first adopter therapy laser customers who has achieved great success both financially and clinically with the MLS laser. I'm extremely pleased with his results and has become a strong advocate for our MLS technology. He's tonight to share some of his recommendations and tips, as well as take us through some of his cases. But before I get over to Dr. Basso, I'd just like to go over a couple of logistical details. The approximately 1 hour in length, plus some time for questions and answers. All phone lines right now are muted, but will be opened during a question break, which will come about midway through the presentation, and will remain open during the protocol discussion. This webinar is being recorded and will be available tomorrow on our customer portal, Cutting Edge Campus. If you have any questions after the webinar, please contact me at the email address listed here. Now I'd like to introduce Dr. Tracy Basso.
Well, hello everyone. First, thank Cutting Edge Lasers for hosting this webinar, and thank them for the opportunity to present to you. It's an honor on behalf to do so. I want to thank everybody in attendance, and hopefully this is a productive discussion for us in enhancing our clinical practices. What I'd like to go tonight is just to discuss a little bit of basic science behind MLS laser and low laser therapy. Briefly discuss the basic effects of laser. We'd also to discuss the potential pitfalls in treatment and dive into some advanced adjustment protocols. Is that me echoing?
Doctor, I'm sorry, we keep getting some feedback from someone. Curtis, could you please mute your phone? I'm having trouble keeping it on mute from here. Okay. Dr. Basso, go ahead.
Sounds great. As you know, this is some of the box recommendations and treatments that are approved by the FDA for the use of MLS, arthritis, tendonitis, degenerative processes, sprained joints, trauma, ulcers, wounds. So it has application in our practice, and obviously these patients are coming through every day. So low-level laser therapy. Basically, it's the application of light to a pathology to promote tissue regeneration, reduce inflammation, and relieve pain. This is a narrow spectral width, and usually with power density between 1 watt and 5 watts. And you start into some physics at this point, but irradiance you can think of in terms of intensity. That's intensity dial on our lasers. Watts per square area, square centimeters, and then that computes to energy, and energy being power or wattage times time. Just things to think about. LLT is typically applied to the energy, to the injury, 4 minutes or so. Obviously, time can vary a little bit, times a week. Unlike other medical laser procedures, LT is not ablative, not have a thermal mechanism, but rather it has a photochemical effect comparable to photosynthesis. Thus, you could use the term laser biostimulation. This has been studied for quite some time, and there's a number of level 1 RCTs that have been published with focus of various pathologies: osteoarthritis, tendinopathies, wounds, pain, neck pain, peripheral nerve injury, strokes. All these entities have been shown at a level 1 research to have positive outcomes with the use of LLLT. The first law of photobiology, how does it work, is the question. So the first law of photobiology states that for low visible light to have any effect on a living biologic system, the photons must be absorbed by electronic absorption bands belonging to some molecular photoacceptor, or chromophores. In other words, you've got a receiver for that light. Some examples of those chromophores would be chlorophyll, which we understand in the plant world, hemoglobin, cytochrome C oxidase, myoglobin, flavins, flavoproteins, porphyrins. Mammals within the animal system, if you will, end up with a particular window. The light, as it varies within wavelength, is going to be absorbed by different tissue. Thus, water has a certain absorption, hemoglobin has a certain absorption, oxygenated hemoglobin has a certain absorption, and melanin. And you can see that on the left and then off to the right, absorption occurs much faster. In the middle, there's what we call this optical window, and that tends to fall in the 600 to 1100 nanometer range, where this range of length, red, near infrared light, penetrates much more deeply into the tissue. And this is the wavelength that can have a clinical effect deeper in the body. It's just a pictorial form excuse me, of this light that's penetrating deep skin into the deep tissues. It's absorbed at the cellular level. It's having an effect within that upon the organelles. Now, typically, at this level, the important phosphor that we're interested in is the cytochrome C oxidase, that's located in the mitochondria. That's our main photo acceptor. It's not only one, but it's the main one. In effect, mitochondrial respiratory chain. Okay, another example. This is, again, within the mitochondria, just getting a little bit more detailed, the various photoacceptors that are there. But what you see with regard to this slide is based on a number of findings. Basically, when tissues have been exposed to LLLT, being increased proton electrochemical potentials, ATP synthesis, RNA synthesis, and protein synthesis, and increases in O2 consumption, membrane potential, and enhanced synthesis of ATP. That's all going on within that mitochondria. So obviously that's significant implications for us. Another key, again, just promise not to leave us at the Krebs cycle for very long. It's the nitric oxide competitive binding that occurs. And I promise you this will be our last slide on the Krebs. Essentially, this is the cytochrome C oxidase specifically, and this is one reason why this is particularly important for what we're doing. Wavelength coming down. You have a number of areas where you see NO, that's nitric oxide, and that's competitively bound to your cytochrome C oxidase. It gets hit with the wavelengths. You see dissociation of that nitric oxide, and then you see increased binding of the O2 molecules. Therefore, you're enhancing oxygen respiration at the cellular level and freeing up nitric oxide, which then also has some downstream effects. It will bind to hemoglobin and myoglobin, for instance, which leads to some vasodilatation, and it can have some other biochemical effects as well. Okay, so I have to leave the Krebs cycle, and I will. So what are the downstream effects? I mean, so we just briefly looked at the molecular level effect of the laser light. I mean, what we're ultimately trying to do is prevent cell death, which is apoptosis, and promote things like proliferation of cells, migration of certain cells, and adhesion, so things are sticking together and healing and putting itself back together. And we see this clinically. The laser light definitely improves a lot of the clinical problems that we see. Blasts, endothelial cells, lymphocytes, keratinocytes are all positively affected by the laser light. Okay, it's just on research level, just briefly, and then we're just taking just nuances here from the literature. LLT enhances neovascularization. It improves genesis, collagen synthesis, wound healing. It's been shown to improve or enhance nerve regeneration, tendon repair, cartilage repair, even bones. Internal organs have been shown to positively respond, and as well, reduction in pain and reduction in swelling and edema. And this just pictorially just what we went over. So this laser light that we're applying is having a positive effect on multiple systems, from connective tissue to the vascular system, epithelium, muscle, and nerve, and bone. So as we apply the energy, there's one kind of a funny physical effect that inherent in this biostimulation that we're undergoing for our patients. And that's called the basic dose response. It's kind of one of those things where you have a little bit of stimulation. Say on the left side of this screen, you have a low energy dose that you're applying to the biologic system, and you get a minimum response, and you increase that dose, and you get a better or increased biologic response. Be tempted to think in terms of a linear response, i.e. more is better. But there's an optimum within specific tissue that you're treating is going to have its clinical, i.e. the optimal biostimulation. And as you increase your dose, see a drop-off that's fairly dramatic. So a high dose and a low dose may have a very similar bio response, i.e. very little biostimulation. And sometimes those are some of the things that you have to think about. That's what I think about in not getting a clinical response. Have I gone too high? Have I gone too low? What might be some parameters that I can tweak to see if I can get an improved or optimal threshold phenomena that takes place with a quick off once you hit that threshold. So some of the potential problems or pitfalls that you might run into, and again, this is some of the parameters that we have. We can affect the dosimetry by increasing intensity. We can increase time. We can increase or decrease frequency. So inadequate or too much energy, inadequate or too much irradiance / intensity can factors that affect our clinical response. Again, thinking back on that curve that we were just looking at. Inappropriate pulse structure. Briefly just state this as this is an area that we don't have to worry about, particularly with the MLS technology. There's been research that's gone into the wavelengths that are used in the MLS. It's also patented tracking mechanism where the pulses are stacked. It has a very high safety profile. The pulse structure is very sound, but simply with respect to a generic comment with regard to all lasers, that pulse structure has to be looked at. And that can be, I know that Cutting Edge has a lot of information on our specific pulse structure. What I've seen is it's very safe and very effective. So I just kind of wanted to highlight that as a key feature in that MLS laser. Irradiation of insufficient area of pathology. This can be the result of the laser not being aimed in the right location. I spent a fair amount of time training my medical assistants who will often assist in the matter into the right orientation of various heads. As we know, the foot is complex and it has contour to it, and it's not always a straight perpendicular laser shot, if you will, to the site that we're trying to irradiate. It might have to be relocated to get the optimal exposure of that specific area that we have in mind, i.e., if I'm trying to shoot or expose the lateral foot, that's the goal. If you come up a little bit farther to the midfoot, you're going to change the angle of application rather significantly just to irradiate properly that dorsal or dorsal area of the foot. Head of the site can play a role. Medication, I briefly want to address this. It's in the and in our to avoid steroidal therapy and non-steroidal anti-inflammatory therapy. I have not found this to be significant personally. I've only used the MLS in the context of non-steroidal anti-inflammatory therapy without any negative effect. I generally observe a 2-week window around steroid injections, but that's cautionary. At this point, I'm just going to briefly stop.
Okay, I was going to unmute all the lines, but it sounds like there's a lot of background noise. So if everyone could just down their background noise, I will unmute all the lines, and if anybody has a question, they can ask.
Any questions out there thus far? Or are they able to use that chat box? I'm just going to briefly stop.
mute and is now muted. Anybody has a question, just click on the raise hand button, and I'll unmute one person at a time because we've got too much background noise. Questions? Dr. Basso?
Okay. So here's only of equipment, the M6, the Me 5, and the Mix. I've been using the Mix 5 for 3 years. I've been very pleased with it. An important thing to remember is that we have two options. You have the charley and the hand wand, and both can be used to very nice effect. And there are times when one dominates over the other, and I've switched back and forth, maybe keeping my power and energy settings the same, and just switching from the charley head to the handheld or back sometimes have a very nice effect. So we have those weapons in our armamentarium. If you have the M6, you have the value of being able to set and expose wider areas, and I think this can also be valuable. Suggested protocols. And I state this as suggested protocols because I don't claim to have the last answer. As I dive into the just protocols, I just briefly want to restate some of the guiding principles that were just in my thinking as I developed these, and have evolved a little bit too. If you have the protocol sheet that I wrote years ago, you'll probably see some variation from what I'm presenting tonight, and free to ask about that. But just reading that the 808 length has a more anti-inflammatory effect, the No 5 has more analgesia. Low frequency pulsed emissions is recommended for more acute disorders. Higher frequencies are recommended for chronic conditions and pain. Have the biphasic response in the back of your mind. More does not necessarily apply and may actually have a significant negative effect in terms of your biomodulation. And about the appropriate pitfalls, proper alignments, etc. Ulcers. We've seen very nice effect with wounds and ulcers. I generally will start with contusion of 5, typical intensity of about 50%, and time will be relatively short at about 2.5 minutes per area. Layman 3 times per week for 2 weeks. I often have a hard time getting patients in 3 times a week, so sometimes we'll simply fall to 2 times a week, simply of practicality. And I generally use the charley head as far as wounds and ulcers are concerned. Modification, that's my clavicle. That's in that picture. Just had to include a body part at some point. Plantar fasciitis, problem that we see, and can respond beautifully to MLS therapy. I typically start with tinnitus setting. And as we go through these protocols, that is a favorite setting of mine. It tends to sit to low middle, and patients do tend to seem to respond very nicely to that. Typically we start low at 50%. Again, it gets to the feel of how long they've had it and how more acute or less acute this might be. I might bump it up to 100%. And I typically will irradiate for 5 to 7 minutes. So I'm often just set tendinitis setting, leaving it on for 7 minutes, which is the pre-programmed setting, and letting it run. We try to get 6 to 8 visits, and I typically will use the charley head, although the handheld sometimes has had a very nice response. Sometimes in the context, if we haven't had an optimal response with the charley head, just switching to the handheld, the hand wand, has made a huge difference. In where I might not get the best response to that 700 hertz and that treatment protocol, I will bump it up to 1500 hertz and leave it at 100% and run it and see how they respond there. So I will play around with it. So if they have more of a chronic condition, I will bump it up to 1500 hertz. Arthritis, so gout, rheumatoid arthritis, etc. Some of the resultant, the tarsalgia that we see as a result, can respond beautifully to the MLS. They're actually one of the cases that sold me on the technology was a rheumatoid patient. The simple tendinitis, 700 hertz exposure, 1 to 2 treatments. I got an email from the Caribbean. First, I've been pain-free for 8 days. She couldn't say, she couldn't thank you enough. It was pretty good to get emails from the Caribbean. That was a nice one. Intensity, 50 to 100%. Again, I typically will start at 50%. Relatively short exposure, 4 minutes, maybe 5. Again, length of treatment is typical 6 to 8, and I'm typically using the Charlie head. Tail and ankle arthrosis, sinus tarsi syndrome. Sinus tarsi syndrome I have found to respond beautifully to MLS therapy. I standardly use the dorsal arthritis protocol here, particularly for sinus tarsi. 10 minutes, and usually I'm going to try and get 6 to 8 treatments. And I'm typically using the Charlie head, and this is where is very important. As you know, there's a particular orientation to the sinus tarsi, and a straight laser shot to that side ankle does not quite get that subtalar joint. So that Charlie head is 45 degrees forward, is up 45 degrees and aiming into that axis of that subtalar joint. Small arthritis and hallux limitis. My protocols, I guess, that I had written early on was for big hand foot arthritis. That's the 500 hertz, 50% at 4 minutes. And that I've gotten is that works well, and we've seen that. I've seen, I will go to a dorsal arthritis protocol specifically for my hallux limitis. I've seen that respond very nicely. So try both and see what is working for you. But keep in mind that particularly with something like hallux limitis, that you might need to bump up the frequency on that. 5 to 10 of exposure, or the 2 to 4 minutes. Again, playing with time is fine. Again, treatment, 6 to 8 visits. Oftentimes, patients that have come with hallux limitis and you irradiate them, they're on their 2nd or 3rd visit, they're asking if they can have their hand irradiated too, because they've got some metacarpal joint that needs some improvement. So, take a head on that. Uncomplicated tendinosis, posterolateral tendon dysfunction, Achilles tendinitis. I'm often finding that I'm applying the tendinitis protocol at 700 hertz. Again, intensity partly vary on patient. I probably will lean more towards 100% than 50%, but it's definitely within my differential of thinking. Just again, has more of a clinical feel on that point. Time, 4 to 7 minutes. Length of treatment is 6 to 8. And again, the Charlie or the hand wand are applicable. Again, I think it's more site-specific at that point. Edema, and I should also include pain, responds beautifully to the MLS therapy. contusion setting, you want to definitely be on the lower frequency sides, typically a 50% intensity. So again, keeping the energy dose low. Time, 4 minutes. Length, discretionary. I would recommend typically 6 visits. And I'll use the Charlie head, and you'll see that's a theme. I've written, I guess, in my early version of my protocols, 100% intensity at 1500 hertz for 2 to 4 minutes. I have not done that since I've written that. So that's getting good result with that protocol. That's great. But I would say my recommendation for post-operative care would be on the lower side for the more acute settings. What about medial calcaneal neuritis, tarsal tunnel syndrome, medial heel pain? It can be a complex problem. I think sometimes this can be a little bit of a nemesis for us, and often be called, a chronic fasciitis or a recalcitrant fasciitis when we may actually be dealing with nerve entrapment. And considering that, and then following the nerve trunks, we'll typically do a tinnitus setting that's 700 hertz, lower intensity at about 50. 2 to 4 minute exposure, 6 to 8 visits. And here the key to me is probably the handheld, and that's purpose that hand is mentioned before the Charlie head, i.e. what we are and what I'm recommending would be follow that nerve with the handheld. And the 2 to 4 minutes would be per site, i.e. go up on the tibial nerve, follow that trunk, follow that medial calcaneal nerve, follow the medial plantar nerve if you can. Test to see if there's any Tinel sign in the arch. Just tap that arch and see if there's a mini Tinel sign. It surprises you. So nerves can be a little tricky. I like the 700 hertz setting, and we will follow that nerve in its course. Neuroma. Same basic principle there. Usually using about 500 hertz. It's the hand-foot arthritis setting. I typically will use lower intensity at about 50, although there's nothing to say that you could not use 100. Typically short exposure of 2 to 4 minutes per location. So the second and third interspace, you might follow those nerve branches a little bit into the arch. Again, a little tap over the medial plantar nerve in its various branches. You might find that you see entrapment within the arch. Again, primarily handled, although we will use the Charlie head too. Neuropathy. We found a couple things. Almost serendipitously, we exposed the patient early on with the dorsal arthritis protocol, just simply in the back of the calf, and the patient, and we had a Achilles tendonitis with that, but the patient happened to be neuropathic at the same time and related a significant improvement in his feeling. So exposure to that posterior compartment may have a very nice effect. We're using a 700 hertz in all locations. And what I mean by that is to follow the classic entrapment points that we see in the leg. That would common perineal nerve as it comes across the fibular neck. And you just simply go up to the fibular head and just come right down below that. And you can often feel that nerve rolling around. That would have a positive Tinel sign. Spend a minute or two with a handheld wand there. Then you can follow the superficial perineal nerve, and you can follow the deep perineal nerve. Usually with the deep perineal nerve, we'll come down to its typical placement, dorsal foot, and expose in that location. That's typically where the entrapment is for the deep perineal nerve. The superficial perineal nerve exits fascial portal about 8 to 10 centimeters above the lateral malleolus, and that's literally sitting center stage between the fibula and the tibia. So if you just feel that lateral muscle compartment, just put you right in the middle of that muscle mass, about 8 meters up, and your superficial perineal nerve is sitting right there. And you can tap that, and you'll get a Tunnel sign, and you know you're right on that location. Ankle brains, typically 5 to 700 hertz in percent intensity. Time 2 to 4 minutes. Sometimes we'll go longer, and like 6 visits. I often will use the Charlie head as well. Dr. Min, he and I were chatting just recently, and I don't know if he's called, but he had a very interesting protocol that came from he had a soccer player, I believe. He was an athlete of some type, but I believe it was soccer, who had a significant ankle sprain. He twice a day of the laser for 3 days, and then 3 following with once a day. And really within a period of time, the patient was dramatically better. So if you can get the patient in more, there may be value in radiating patients on a more frequent basis. Tungus, I'm briefly going to, this is obviously a non-approved utilization of the laser. And I have seen improvements with the application of the laser. Typically, I use a CW, which is a continuous wave, typically 5 to 10 minutes, accent on the 10 minutes, and exposing all affected areas. And so, I mean, if we have 2 nails, I expose the 2 nails. If we have 10, we do all 10. Healthy nails, we don't bother exposing if we have to. I will expose the patient weekly, 6 weeks, and then I start to follow them every other month, with expectation that they may need a booster along the way. And typically a booster will be a 3-week string of treatments with that same protocol, 5 to 10 minutes of a continuous wave to the affected area. Would you say this is off-label use? And I want to emphasize that. In summary, again, just thinking about some of those parameters that anti-inflammatory and an analgesic effect to your liver. The lower frequencies are recommended more for acute inflammation. The higher frequencies for chronic pain. Most of that biphasic effect in a scenario where the patient is not responding the way I want them to. Just thinking about some of the practical pitfalls, and then also just being comfortable that there's really no setting or prescription that is universal for all patients. Everyone's going to be a little different, and we do have to play a little bit with things. And with that, I will say grazie mille. Thank you very much for everyone attending, and we're going to open it up to discussion and whatever else you may have for us. And I just want to thank everyone for their kind attention, and also thank Cutting Edge.
Thank you.
Back to you.
I've got a question from Dr. Titko. Dr.
Thanks, Tracy. I appreciate your time this evening. I really have several questions. I've been using the laser for, I think, just over a year. My laser technician asked me today to ask you how I would know if the laser is decreasing, after how many uses, how much time, how will I know that the strength is decreasing and need some maintenance. And 2, I'm still really confused after a year of using it as how do I decide what change in the wavelength do I need to make? What change in the time do I need to make? Am I increasing this, decreasing that? I have a disservice to my patients to experiment on them while charging them for this experiment. So I'm looking for some way to make an intelligent decision when to change my protocols.
Great. Let me take the second one first. I always charge. I do leave a little wiggle room. So if I feel like I have to modify my settings, I will do that pro bono. And I tell the patient that. I say, well, we're not getting the response that we're looking for. Let's play the settings, and if this is a thing, it's fine. I'm ready for that because my interest is the patient. So there is a little bit of that. And obviously, if you hit the home run, it's great and everyone's happy. But if you don't, there's times when that occurs. We need to play with settings, and I'm upfront with the patient. Oh, true. There's also not there. I mean, there will be some clinical failures. Having that, I'm pretty OCD about not having that occur, and I'm going to try and play with those settings. And I typically will use a guiding principle. The 700 hertz setting, the tendinitis setting, really I have found really does seem to have some clinical effect on a lot of people. So in some ways, you've already gotten on board or got the patient on board with that laser. It's a matter of, okay, maybe we need to turn it up or turn it down a little bit, see if we can get a little better response. And it's just communication with the patient, engaging their satisfaction. And that's obviously important. I mean, that's ultimately what it's all about, is patient satisfaction. For the maintenance of the laser, I'm partly going to leave a little bit of that question for cutting edge. My understanding is you can take a cell phone and take a picture, a digital picture of the laser as it's being exposed, and you will see that laser in that digital picture. If you don't, you have an exposure problem. I don't think you're going to see any strength loss. I think, and this is, I'm a technical person. I've had very little problem with my laser, but I would expect the laser either to work or not to work, as opposed to lose strength. And then I would start looking at other things where I suspect the laser if I wasn't quite getting a response, i.e., is the medical assistant exposing the proper area? Early on, I found that. I sort of assumed that my medical assistants knew the foot better than they did, and I would come in and see the treatment going and just quietly pull my hair out and gently go, let's try this area here. So it just depends on how intimate you're involved too. And for me, sometimes in a busy clinic, we hand stuff off to our medical assistants and to our friends. Sometimes it doesn't always work. But then that's just part of training and communication and just keeping that line of communication going. I hope.
Yes.
Byron, I'm going to add one comment too, that as we adjust those settings, please understand that there are negative side effects. We can't hurt anybody with a laser. So technology is extremely safe, to adjust dosages and go a little bit higher if we feel like we need to get a therapeutic response.
The question we have is from Dr. Molesky.
Yes, I see. A protocol attached to the machine for a couple of years now, and I've used it off and on. I get advice from another contact through Cutting Edge to utilize no more than 27 joules on the small head and 175 on Charlie head. How does that feel to you? Because a lot of the things you discussed today show like more than that many joules, and you really didn't discuss joule exposure.
I typically have just worked within the parameters that are on that laser. It's true. You've got to do the math equations at that point.
Well, ours always shows the amount of joules you're going to get with a particular setting.
And the joules on the right?
Yeah.
For total.
Right. That sounds kind of low compared to what you're putting out here. So.
Yeah, exactly. Those are certainly much lower settings than what I'm used to using. Yes.
Okay. So and what Brian said is you can't really overexpose a patient per se. We've had a few people complain about pain, or really nobody.
Yeah, no, the safety profile is excellent, as you know, on the laser. So you really, one thing that is really safe with the laser, then it's a matter of, are you getting the clinical response? And if you are, certainly we'd like to hear about that. Those do seem a bit low, I think.
Okay, thank you.
Jeannie Lindley has a question. Jeannie?
What patients with symptoms of shingles and nerve problems, would this help patients? Because see that it helps nerves.
I would definitely recommend it for that.
What kind of setting would you put it on? Just...
I would start around the 700 hertz.
Okay.
And then I would look for the entrapment locations where that common perineal nerve is coming in, the superficial and deep perineal nerves. Look for a Tunnel sign. If you have a positive Tunnel sign, I would irradiate over that, and certainly a tarsal tunnel as well. We've in some cases just recently. This last December, had an interesting case of a patient with chemotherapy that then had shingles that kicked in after her chemo was done, and she had severe pain, and it was due to a common perineal nerve entrapment. Ultimately, we were able to relieve her pain rather dramatically with a neurolysis procedure, but laser would have been very applicable in that scenario. And if you've got that, I would definitely consider laser.
Okay. Thank you.
Dr. Morse has a question.
I got a question. In California, how high can we go with the laser? As I have patients asking me about their knees.
Well, I'm going to leave that to Mr. Rafflesberger. Our scope of practice is, we can treat anything that, controls the foot. So,
Anybody requested a ruling on that or an interpretation?
Not aware of, and I hope not.
Okay.
Between you and the wall, if you're comfortable doing it, I will occasionally. We treat knee pain with orthotics.
Yeah.
I'm not doing anything invasive. I personally don't have much discomfort doing that. But and you have to know your patients. But anyway.
Okay. Thank you.
Dr. Jacoby?
Can you hear me?
Yes.
I'm wondering how your results are long term. I've had the machine for about a year now, and I get good results in the near term, but long-term results, I just haven't been able to get great results. So I'm curious your experience, how long it's lasting, and are these patients come back long-term multiple times?
Excellent question. I would say long-term results are good. First of all, I've been using it now for 3 years, and it remains a regular part of my practice. It depends on the pathology that you're treating and your overall expectations as well. I think laser in terms of inflammatory and pain. And if a cortisone injection, do I expect every cortisone injection to have a lasting, permanent effect? Not really. I'm only doing other things to enhance and ensure that long-term result. And to me, there's not much different. I mean, you have to remember you're doing some biostimulation. You're not doing an ablative thermal procedure per se. And so, to me, this is excellent adjunct therapy with everything else that we're doing. I don't consider laser as the singular thing you use or rely on. There's nothing in my practice that's singular in a way. I mean, usually we use multiple treatments. You know, heel pain, the orthotics, do the bionics. You're going to look at shoes. You know, if they're having chronic pain, I mean, you're going to end up ordering a bone scan. You know, what else do you need to do? I mean, you're still working this patient up. And so, you know, it's just treatment in real time. The thing that came to my mind, though, when you were mentioning this was, this is a great case. You know, you talk about serendipity. 4 months into having this laser, you know, I had the laser safety officer of the UC Davis Medical School come in as a patient. He had a old calcaneal fracture, you know, thus mild to moderate subtalar arthrosis. Looking for a cortisone injection and an update to his orthotics because that's what had helped him years previous. I did the laser to him, and we did the orthotics. I did 6 treatments of laser on that sinus tarsi and eliminated his pain. And put him in the orthotics, which I subsequently had to adjust. But once we got adapted, it was good. And I've, you know, subsequently heard through the grapevine he's still doing great. You know, I think it's always patient by patient and certain expectations. And I think sometimes we think laser still with regard to some surgical process that we do, and this is a therapeutic process.
Okay. I've had some time where I've had patients come in and say, "No, I don't want to spend any more money because I felt much better, but it just didn't last." So I asked. Yeah,
you know, I mean, I can't say that I've dealt much with that, but there's an element where, again, I'll be up and if I'm not happy, I start to play with those settings and see if I can't find that medium. And there's plenty of times, I mean, in that scenario, I won't charge the patient for further visits if I don't feel like I'm accomplishing something. That doesn't happen that often. I mean, that's not a common thing, but it does happen from time to time. You bet.
Byron, anything you wanted to add to that?
I think Dr. Basso's answer was just spot on. You know, the safety margins are certainly there to be able to, you know, adjust those. Of course, chronic conditions, you know, folks might need some sort of maintenance because the neuropathy, for example, is not going to go away. So once you get the pain management under control, patients might need, you know, some sort of monthly maintenance or quarterly maintenance. You know, as Dr. Basso also said, everybody's an individual, so we're going to look at them individually, and you know, some folks might need a treatment once a quarter in order to keep their pain level maintained. Folks might have to come in once a month. So
the only thing to add too is just think about how applying the laser. Is there a potential problem either in the application, in its direction, in its intensity? Is there some issue? And I remember, and I've in the work at Cutting Edge, I was getting calls all over the country of various people trying the laser. And there was a guy in Texas that just he couldn't seem to get any positive effect. I would just scratch my head, and I couldn't help but wonder if there was just something that wasn't being done properly. Are you 20 centimeters away, which is roughly 8 inches? Is it properly directed at the foot? That was that I saw with my medical assistants. They were not properly directing the the beam should be perpendicular to the area of pathology, and be tangential to the top of the foot. And I would just understand that three-dimensional thing, and sometimes scratch my head when I was seeing that it wasn't applied. So that required education. I don't know the answer to that. Just some thoughts on that.
Other questions? Stephen Haber.
Tracy, I have an for you regarding the use of the hand wand or the head. It sounds like you're talking like either or. I use the hand wand or use the Charlie. Do you not use both? You put them on the Charlie head first, pointed at a certain specific area, and then the hand wand either on the area as well or on your trigger points in the vicinity?
You can't do that. I think we probably fall to more of an either or. You can use those lasers simultaneously, and actually that's an important point. Thank you for bringing that up. Particularly like with neuropathy, where you're covering a broad area of the leg, we'll often do that. So we'll be irradiating an area and then using the handheld and moving it around. Something inherently lazy, and we'd rather use the Charlie head and come back in 4 minutes or whatever it is.
Okay, you're not often using both at one treatment.
I didn't use the word often. We do that. We did today, as a matter of fact. And it's just more clinically driven at that point, depending on what wants done. But you try to, there's a level of efficiency for me that if I can prescribe a treatment that doesn't require staff, I will do that. Because certainly have enough fish to fry that if I have to tie someone up, I'd prefer not to.
Thank you.
Well, I'm not seeing any other questions. Any help? Okay, before I go over some of this information, is there anything that you wanted to Byron? And let me just add, for those of you who don't know Byron, I'm sure most of you do, he is our divisional sales manager, so can answer quite a few of these questions as well.
I just wanted to personally thank everybody for coming on and taking time out of their away from family and things to participate in this, and just thank everybody for their participation and their time. And cutting edge, we're here to assist you in help folks manage their pain and doing it in a safe, non-invasive way. And thank you all for those that are current customers and you that are on the call that are thinking about being customers. We encourage you to continue to ask questions and reach out to us, and we're going to help and support in any way we can. Thanks again for your time.
If you have any additional questions or comments after this, please feel free to send them to me. My email address is right there, lmaloney@celasers.com. Recording this, as I mentioned, and the recording will be available on our customer portal, Cutting Edge Campus. And those of you who are our customers should have recently received a package describing Cutting Edge Campus, so please visit that. There's lots of material on there for you. And finally, I will be sending out an evaluation survey tomorrow. If you wouldn't mind taking just a moment to fill that out, we would appreciate your feedback. Thank you much, and thank you very much to Dr. Basso. Good night, everyone.
Thanks, Basso.
Thank
Good night.
you.